Our next speaker is Dr. Sheila Raja, Associate Professor and Clinical Psychologist at University of Illinois, Chicago. Dr. Sheila Raja is a licensed clinical psychologist and author of Overcoming Trauma and PTSD, the Sexual Trauma Workbook for Teen Girls, and the PTSD Survival Guide for Teens. She is an associate professor at the University of Illinois at Chicago, where she teaches health communication and behavioral medicine. Dr. Raja received her PhD from UIC and completed her internship and postdoctoral training at the National Center for Post-Traumatic Stress Disorder in Boston. She has authored numerous peer-reviewed articles on the relationship between trauma and health, and has given invited talks at the international and federal level on the topic of post-traumatic stress and trauma-informed healthcare. She worked with the Office of Women's Health, U.S. Department of Health and Human Services, as project co-director, creating a comprehensive online, case-based continuing education course on trauma-informed healthcare. Dr. Raja has a passion for making evidence-based psychology accessible, and she is a regular guest contributor to local and national news outlets, including CNN, HLN, ABC, and CBS. Please join me in welcoming Dr. Raja.
Thank you so much for having me today. I really appreciate it. It seems like you have such a wonderful day that you're in the middle of, and so many important speakers and such great discussion. I got a chance to hear a little bit of it. I actually just came from the medical school where I got a chance to give a variant of this session to our first year medical students. And so this is a little bit different for me, this audience, because I'm used to training healthcare providers. So I usually have either all nurses in the room or all dentists or all physicians. And I kind of like this because I think this is going to be fun, because for me to get in front of an audience that is very varied stakeholders. I mean, you guys are, you know, I kind of got the fill-in here about how many different backgrounds you all bring. And so in many ways, I often talk about what individual clinicians can do, because that's what they want to know. And then I kind of plant the seed about public policy, going, yeah, but please care about that too. So this is fun, because I'm going to spend more time on, you know, the public policy in hopes that you all are kind of the people that can get out and influence some of that. So I'm going to just talk a little bit about some of the things you already know, which is the prevalence of various types of traumatic events. I'm going to talk a little bit about how we in healthcare have kind of operationalized how we can help people deal with these kinds of things. And then what are some future directions in trauma-informed healthcare? And ideally, I'm actually going to try to go through my session quickly so that I can have 15 minutes with you all to get your ideas, and you can kind of help me shape what some of the agenda is, because it's not often that I get to have such a varied audience in front of me. So as a psychologist, you know, the way we define traumatic events is basically somebody has been exposed to something that's either, you know, where their bodily integrity, they witness or are threatened with death or harm, or somebody close to them is threatened with that. So that's things like motor vehicle accidents, natural disasters, sexual assault, interpersonal violence, homicide, suicide, elder abuse. There's also this concept called toxic stress, which you guys have probably all heard of. And there's a really nice website, for those of you not familiar with it, there's a guy named Jack Shonkoff out of Harvard, and he has a really nice website. It's called the Center on the Developing Child, and they have a lot of information on toxic stress. But basically, toxic stress, in addition to trauma, which can be single incident types of things, toxic stress is usually something that happens to us as children, and it's prolonged. And often there is a lack of adult support or a caregiver, someone buffering in our lives. And so it's things like abuse or neglect, living in poverty, having a caregiver that might be mentally ill, for example. And we know from longer term studies that, and some of this is, you know, we're just looking at this literature, but there are developmental periods where if those things happen to us, it actually really takes a toll on our brain development and our physiology. I think there's a practical definition of trauma, so it depends on the audience you're in front of, right? I mean, if you're in front of people where you really have to convince them, you can go real clinical, but you can also, you know, when we're talking to community stakeholders and when, you know, some of you are from the community, so when you're educating people out there, trauma is non-consensual. We don't ask for it to happen to us. We feel in discomfort or fear or intimidated. Our bodily integrity or somebody close to us is violated. And we know, unfortunately, that trauma is prevalent in the United States, right? Child abuse, for example. More than 5 kids a day die in the United States. 1 in 4 girls and 1 in 6 boys talk about childhood sexual abuse. And these are in large epidemiological surveys, which, again, the way, I know we have public health folks in the room, we used to do those through, you know, random digit dialing of our community members. And I asked my medical students this morning how many people have a landline, and nobody raised their hand. But of course, now we're trying to reach our communities through, you know, different ways of surveying. But I think what's remarkable to me about some of these statistics is that they're often collected without you having a relationship with that person. And these people are saying, yes, I've been through this, this, and this. So, you know, people are suffering from trauma. Also, you know, sort of trend-wise, we know that younger kids with special needs are often the most vulnerable to child abuse. We also know, for example, that, sorry about that, that intimate partner violence is also an issue in our culture, that about 1 in 4 women in the United States talk about experiencing some kind of violence. Sometimes, depending on the surveys, you know, that kind of abuse can be mutual in relationships as well, but it's often the woman, if it's a heterosexual relationship, that experiences more harm. But again, we still need to be asking about a lot of these issues. Interestingly, I don't know if I have that statistic up here. I think in the interest of time, I'd probably cut it, but about 5 women a day in the United States are actually killed by either a former spouse, current spouse, in some kind of interpersonal violence situation. I do these talks in variations all over the country and things, and I was in Canada a couple of years ago, and I had to redo all my statistics for Canada. And most of it was the same in terms of sexual abuse, child abuse, but women dying in interpersonal violence was a lot different per capita up there. And this was about 5 years ago, and I looked at actually my audience and I said, what's going on? I don't get it. And what do you think they said? Yeah, I mean, they looked at me like, what, are you new? And they were like, it's our gun laws, right? So I'm making a point here that a lot of different violence, we used to study violence 20 years ago of like, I do sexual assault, you do combat, I do domestic violence, you do community violence, but we know trauma is interrelated. You know, and that's part of the kind of case that I'm making here. Elder abuse, not something we think about that often, but it's not just physical or sexual. It can be emotional abuse. It could be not taking, you know, mom or dad who can't access their finances or maybe go to the doctor or get care. Again, we have done a really good job in the last 10 to 15 years where people are living longer, in some of our communities, but are they living better? Do we have supports in place for people to be able to age in place with dignity, where families are not overwhelmed? And so elder abuse, those are all factors that make people and families vulnerable to elder abuse. And it's probably vastly underreported because it's often things that are going on within, you know, people who are known to each other. That's a similar thing with you know, sexual assault. It's probably underreported because it's happening when people know each other. Combat exposure. It's important for us to think about that about 7% of the population has actually been, you know, exposed to combat, either in the military or they've immigrated here from countries that have experienced some kind of war. when you have veterans that you're serving or interacting with. There's military sexual trauma that sometimes happens. Okay, and community violence and firearms. Another issue. Approximately, and again, this is last year's statistics, I think. So we have about 30,000 Americans that die every year from firearms, if you include dying by suicide. Okay, it's about 12,000 homicides a year. I don't need to tell this audience this. I think we know this. The U.S. is home to 5% of the world's population and about 30% of the world's mass shootings, and every year it's getting worse. I mean, this is not sort of a me being pessimistic kind of thing. This is what the data says. And you know, I've been giving variants of this talk for many, many years now. And I've had to update this slide because the Centers for Disease Control used to say, if we don't get a hold of our firearm issue and our gun violence problem, as many Americans are going to die by a gunshot wound as they are in motor vehicle accidents. Well, that happened in about 2018. Now that is the case. If you include you know, suicide, if you include firearm accidents, if you include community violence and all of those things in it. So we have a problem. Many of you work in communities or live in communities, serve communities where the PTSD rates, the post-traumatic stress disorder rates are as high as what our military veterans are experiencing. So what does that mean for, you know, our community members, for ourselves even? And of course, there's always populations that are the most vulnerable to trauma, right? Our seniors, homeless individuals, people who may be dealing with HIV/AIDS, refugees. What I think is remarkable about trauma work is that, I mean, sometimes people will say, wow, this is really depressing. And I usually feel right around this point when I give this talk, I feel the energy in the room is like, you know, people are like, wow, this is pretty heavy. She's making a good point here. And I promise you, I am going to talk about resilience and things we can do. And I also promise you I'm fun at dinner parties, which nobody believes me. Nobody ever believes that. And people will say, you know, why would you study trauma, right? Why would somebody even do this, or why would you want to go do this work? Probably people have asked you that. Like, why would you want to engage in this kind of hard work? And I think, you know, this is the thing that we have when we're dealing with, you know, violence, trauma, toxic stress. We have so many options to intervene. If you are a medical provider, you may get in on the sort of the neurons, right? The stress reactions, what's happening physiologically in that person's body. I may, as a psychologist, go in with that person or that family. Somebody who's in public health may say, hey, I'm going to shape public policy. Or somebody who works in the community, they may go in at the neighborhood level, the national level. So there are so many points that we can kind of intervene on this, that I think that part is actually kind of a hopeful thing. Many of you have probably seen this in different ways. I think one of the things I'm going to talk about is how can we educate people in layperson's terms about what's going on with them when they've gone through toxic stress or trauma. And I think one of the things that's important for us to remember is that not only is our body getting ready, often many of you guys have heard this fight or flight response, right? Where, our heart is racing, we're perspiring, our pupils are dilated, we are getting ready to run away or fight a threat. But also, there's what we call our HPA axis. And so the end result of this process is that our body secretes stress hormones, also known as like cortisol, okay? Cortisol in the short term is not a bad thing. It helps us to get ready. The problem is if we are chronically stressed, or we're chronically triggered because we can no longer figure out what's safe and what's not safe anymore, our body is chronically triggered for that. And we know that that's not healthy for us. So one of the things that just for us to all be able to understand, and I think to explain to our communities, is the fact that that kind of reactivity in the body, the central nervous system, the hypothalamus, pituitary, adrenal cortex, that's what that stands for, that stuff is damaging to the body. That basically, if your blood pressure is always going up because you think you're running away from a threat, like your body's getting ready for that, in the short term, it's fine. In the long term, that damages your blood vessels. And if you damage your blood vessels, what disease is that associated with? Heart disease, right? If I'm continually secreting insulin because my blood sugar is going up and I'm trying to, get ready and get energy to get away from a threat, what disease is that associated with? Diabetes, right? I mean, so we're making all of these connections, both, from the health research, the neuroscience research, the public health research. We also know that when people have been traumatized, they're often not coping in healthy ways necessarily, right? Sometimes I'll ask audiences, how do you deal with stress? And I'll always have somebody say, well, yoga. And I'm like, well, good for you. That's not off. I mean, yes. However, sometimes people are coping in some ways that aren't great, right? They're ordering an extra pizza or having extra cake. Maybe you're engaging in high-risk sexual behavior because you just don't want to think about everything going on. Alcohol, smoking. Once I was doing an interview with a client, and I had asked her, I said, you're coming from a neighborhood where there's a lot of violence. She was talking to me about how she was coming from a neighborhood that there was a lot of community violence. And I said, how do you think that affects your health? And she was an African-American woman, and she lived on the South Side. And she said, nobody's ever asked me that question before. And she goes, huh. Now that I think about it, she goes, I'm raising a Black son in America today. And when I get an alert on my phone that there's been another shooting in my neighborhood, I do reach for some chocolate. And then she goes, that can't be healthy, can it? And I mean, it was interesting because nobody had helped her kind of just even think about, like, sometimes the way that we cope with things. And she said, and I'm diabetic, that can't be good for me, I suppose. I mean, I never thought about it, but that's when I see the alert, that's what I do. So part of it is us kind of putting the pieces together for ourselves, our community, the clients we serve. When I educate medical students or dental students or nursing students about this issue, I'll say, okay, here's the mammogram, for example. I mean, this could be a mammogram at Loyola, right? But imagine if you're a survivor of sexual assault and, the clinician, for those of you who've gone for the mammogram, this is real. They tell you, hold still, don't breathe, don't move, right? Imagine if you're a survivor of sexual trauma and you're told that. Like, how triggering is that? Okay. Imagine now this is an MRI, right? But let's just say that you're a veteran and you have PTSD and you hear, you need to relax, lie still. You might hear some really loud noises, thumping, feel some air, right? How triggering is that? You're at the dentist but you're a survivor of childhood sexual abuse and the dentist says, just lie back and relax, try not to move suddenly. Right? These things, in medicine, we need to put together the fact that, like, we have a lot of people that may be walking around okay, and I'm going to talk about resilience, but there may be moments that some things do get triggered. And so what can we do? Imagine you're at the ophthalmologist, but you're a survivor of domestic violence. And then, they're like, I just need to get close and it's dark and they need to take a closer look. How triggering might that be? Okay, you're going over your labs with your provider, but you live in a community where there's violence on a daily basis, so you need to stop smoking and eat better, but you're also dealing with all these stressors in your daily environment. So, I mean, these are things I think in medicine that we really need to think about. So from an individual basis, a couple of years ago, about 5 years ago, we developed this pyramid around trauma-informed care. You guys have all, I think, heard this term, trauma-informed care, but let me kind of define it for you. SAMHSA, which is the Substance Abuse Mental Health Services Association, they have a website where they've sort of outlined different principles of trauma-informed care. But if I were to break it down, I would say that really in medicine, what I think we care about is that everybody from the front desk staff onwards really understand that trauma is prevalent, that trauma takes a toll on health, and then avoid re-traumatizing or re-triggering. It doesn't always mean screening or asking about people's experiences. So let me talk a little bit more about that, because I think we also need to remember that resilience is the norm. Lots of people walk around with lots of things. You all are probably walking around with something in your past that may feel like it was stressful, traumatic. You know, I'm a human being too. So, but we also have a real capacity to be able to heal from these things. So the question is, you know, at least within the healthcare system, what can we all do to support that? So one of the things that I sometimes go over with folks is like, when people are traumatized, right now I'm writing a book, the book I'm writing right now is on resilience. So I'm like deep into sort of thinking about all my clinical experience, but also what the literature says on resilience. And so I promise I will make sense of some of these slides. So basically, when we look at what predicts resilience, one of the things that I tried to highlight for you are what are some of the ways that I'm always interested in, what can we intervene on? Like there's certain things where I'm reading it and it's like, you're higher in neuropeptide Y. Well, I don't know if I can help you with that. As a psychologist, there's nothing I can do, right? I don't think. But what can I do? What can you do as a community provider? What can you do as a clinician? You know, wherever your point of service is for helping change this dynamic, what are some things that we can do to intervene on trauma? We do know that before a trauma happens, that if we are providing support for depression, so people don't go in depressed in the first place, they're able to be more resilient when bad things happen. That makes sense, right? Nicotine use, interestingly, is actually a bad predictor for people being able to heal. So again, engaging, like helping people not smoke in the first place. I have childhood IQ is something we can change, because I believe as a psychologist, we can change that. Because IQ is not just sort of you're born with that. It's, do you have access to early childhood education and support and nutrition and all of those types of things? So we can get in on some of that as well. Emotional tolerance, fancy psychological word for, do we teach kids, and this isn't sort of a, gee, you just have to take all the bad things. It's, do we have families and communities where we can talk about distress, where we can talk about stressful things, and we can talk about how to cope with them. We can sort of be open about some of those things. Can we treat maternal depression? Can we give mom and dad support that they need? Can we teach mindfulness? So also during the trauma, people that blame themselves, that's a worse thing. We have a huge opportunity to intervene as a country on that sort of thing. Like instead of blaming and shaming trauma survivors, we can decide we're going to believe people, we're going to help people that are traumatized. We can help people deal with their anxiety if something bad happens. Afterwards, we can provide people with social support. Again, we can try to help them not cope in ways that are unhealthy. We can get in on the shame and say, we believe you, you didn't do anything wrong, like we're here for you. Sadly, litigation and compensation. I do a little bit of expert testimony now and then, and it's not great for people, right? I mean, that it is, we need to educate our legal system too about how to treat survivors of different traumatic events better. Active coping, that's just a fancy word for saying trauma makes your life really small really quickly. Often we start avoiding going places, doing things because we're afraid of being triggered. So if we can find safe ways for people to still stay active, it's really important. But part of that also involves, if you're living in a community that doesn't quite feel safe, we also have to try to change community safety as well. Exercise, physical activity, looking at things differently, that's cognitive reappraisal is the fancy word for that. Altruism, moral purpose, the idea of like post-traumatic growth. How do we find ways to make meaning of things? That's not easy, by the way. For those of you who are like really kind of data geeks and want to look forward, you can ask me for this slide, I'll send it to you. This is a nice review of resilience factors. Okay. So for individual clinicians, I'm just looking at my time. Okay, I think we're good. I often will teach individual level clinicians about sort of this trauma-informed pyramid approach, right? Which involves things like patient-centered communication, explaining how how trauma impacts our physiology and impacts our coping. Collaboration, patient-centered medical homes, knowing social workers, behavioral health providers, community resources, places where people can heal, and also taking care of yourself as a provider. All of us in different ways need to take care of ourselves. So there's an article on this. If you're interested, I can send that out to anybody. But basically, these are just good patient-centered care skills that every clinician should be doing every time with their patients, right? Talking to them, explaining what's going to be happening, giving them, an overview of the appointment, asking them what they can do to be more comfortable in an exam. Again, understanding that stress impacts the way that we cope. So just educating people. You don't have to know what they've been through to say things like, sometimes when we're in stressful situations, we may cope in ways that aren't great for us. And I would use the word us in that, because that way it destigmatizes it. So often people come in and they're like, yeah, no, I'm doing this, I'm doing that. I know I shouldn't be. For example, with substance use, I'm not going to go down the wormhole, but we've learned a lot more about, there are people that use substances maybe that don't have a trauma history, but there are a lot of people that use substances and they do have a trauma history. And what that means is they have to both learn how to cope differently, but also maybe how to address some of what's happened to them. So I think as a culture, we've learned a lot more about not blaming and shaming people for substance use disorders. Okay. So educating people about that kind of thing. Learning where to refer people. Again, collaboration with communities, this is exactly what today is about. Collaboration between public health and community agencies and medicine and dentistry and everywhere, right? Also understanding when we have to report violence and trauma and when we don't. I always tell people that you have to report child abuse and elder abuse often in the roles that you're in, but legally you don't have to report other kinds of violence. And often people will know better, about, well, I don't want to report this domestic violence situation right now because it's too volatile right now. So again, this is where interprofessional collaboration, working with a domestic violence agency, working with an advocate, helping that person, but not giving them too much advice if that's out of our league. I used to have a slide that says, this isn't in my job description, not in a bad way, like, oh, that's not my job, but know sort of who to collaborate with and who's there and has more expertise on something than you do. Okay, this is just some references on mandated reporting. Also understanding our own history. We are all providing care and help to people. That's why we're in this room. We are all human beings. I have learned this the hard way. You're a psychologist and you just learned everyone's a human being. Sometimes we see people only as professionals in the room. I've made that mistake. I have done that many times. I just gave the medical students this example, so I'll give it to you guys too. So about a couple of years ago, I did a seminar in our medical school at UIC, and I had about 20 students that signed up for this elective on trauma-informed care. And it was a 4-week, couple hours a week. And the last session, we had a standardized patient. That's a medical actor. So a medical actor came down, and they were supposed to role play how they would deal with this traumatized individual. And nobody was volunteering. Because as you can imagine, if I asked you who would volunteer to do that, you'd be like, in front of everybody, no thanks. And there was one student, I'm gonna call him Sam. He was really, Sam was really engaged the entire class. His answers were always spot on. He was very empathic. I felt like Sam was gonna do a great job if he volunteered. And I kept looking at him. I'm like, is he gonna volunteer? And he didn't. And nobody volunteered. And I just really wanted this to be a successful experience for the class. So I'm like, Sam, can you please volunteer? And so he did. He was a respectful guy, you know, and third-year medical student, came down, volunteered. And afterwards, he told me, he's like, Dr. Raja, that was a really difficult experience for me because I just took my 13-year-old niece for a rape exam on Saturday. And I was like, okay, I am so sorry that I did that to you and I put you in that position. I just, you know, I learned that we are all human beings. We're all human beings that come into the room with different things that we're dealing with. And so there are things like compassion fatigue, vicarious or secondary trauma, burnout, moral distress. These are all things that we're dealing with. Let me see if I've defined these words. Yes, I have. Good. One of the things we can educate people about, trauma stewardship. This is the idea is that when you are doing your work and you're doing it well, it takes a toll on you. It's kind of supposed to, but it's really difficult also. There's a nice book on this issue too. The trauma stewardship is the idea of how do we care for ourselves in order to avoid the negative effects of caring for others? How do we replenish ourselves? Compassion fatigue is this idea that sometimes we feel like we cannot emotionally regenerate ourselves. We don't need to be directly in a helping field to experience compassion fatigue. Like the person at McDonald's can experience compassion fatigue because at some point they're like, you know what, I just cannot deal with another rude person today, right? Okay, vicarious trauma though is often when we're in a helping profession. It's that shift in our worldview when we're always exposed to trauma. So sometimes I tell people about the fact that, so when I trained at the National Center for Post-Traumatic Stress Disorder, and that was like 20 years ago now, basically it took a toll on my worldview and I didn't know it was happening. And one day I was in my car, I'm in Boston, and you know, the guy in front of me stops really suddenly in traffic, and I looked at him and I'm like, I wonder if he's a rapist, or if he beats his kids, or if he's a pedophile, or, you know, that's exactly what went through my mind. And I'm like, wow, I think the world is crazy at this point. Like I've really gone, you know, it was interesting. I really hesitated to bring it up with my supervisors that was happening to me because I thought they were going to tell me, you know, you're just not good enough to do this work. You don't have what it takes. You're not tough enough. In fact, they did not do that. They said, you need to take a couple days off. We're going to look the other way and not count it towards, you know, and unfortunately we didn't have policies that support it. I was an intern back then. We got 10 days off the entire year, including vacation and sick time. They've changed that since then. So I didn't take a day off. I never took a day off, right? So they were like, we'll just let you take 2 days off to just hang out, but we're not going to report it. It's fine. So again, if you don't want that to happen, you need to also figure out larger institutional supports. So this is also called secondary traumatization. Burnout. That's when we get to the point where we are physically and emotionally exhausted. We have low job satisfaction. We have a high workload. We feel powerless. You can resolve that by changing your job sometimes, whereas you know, vicarious traumatization, compassion fatigue, we take with us. We take with us to the next setting. Burnout, it might change with a better supervisor, a better set of policies. Moral distress is also interesting. This is sort of this thing where the institutional constraints prevent us from responding ethically. And that's often faced in healthcare and behavioral health, where we might want to do the right thing, but we feel like we can't. Okay, so sometimes I will tell providers that most of this stuff that I'm talking about are things that we could do with every patient every time, right? We can use good patient-centered care. We can educate them about the health effects of trauma. We can take good care of ourselves. We can have good collaboration with our communities, with our other professionals. So I have this picture up here where I say, when did healthcare providers start wearing gloves around HIV prevention? Like, when did they start wearing gloves to protect themselves from HIV? What? Any ideas? One of the med students said the 90s, by the way, this morning. Like, it was the 80s, yes. Thankfully, there may be some people that remember the 80s. Yes. What were we doing before that? Washing their hands. How were healthcare providers deciding who's at risk for HIV? Does anybody remember that? They had these risk groups. So it was the 4 H's. Does anybody remember that? The 4 H's. Homosexuals, Haitians, because that was a big group that was infected and struggling. Hemophiliacs, and I think like heroin users. Yeah. 4 H's, which is interesting, right? And then at some point in the 80s, healthcare decided, you know what, we're all just going to wear gloves because I can't look at you and go, well, is that you? I don't know. So we started to just decide, let's use universal HIV precautions. And I think that's where we're at with trauma, right? Is let's use universal trauma precautions. All of these things we've been talking about, we can do with every person that we've interacted with. We can educate, we can take care of ourselves, we can create policy. Sometimes you may be working in a high-risk situation, right? You may be working in communities that are very affected by violence. You may be working in, a clinic where you see a lot of trauma. In which case, if you have an integrated setting, you may decide to screen for trauma. I've been recently doing some work with Nadine Burke-Harris, who is the Surgeon General of California. California just got $80 million to screen for adverse childhood events in all their clinics. I'm not sure how I feel about that, and I'll tell you more about it and sort of some of my thoughts on that. I think that sometimes we can screen for trauma and ask every one of the people that we work with, what have you been through? I also think that sometimes people may not be comfortable, depending on their relationship with us. Is it a long-term relationship? Do I have people to refer you to? Can I assure your confidentiality? Does this go in your chart? Can insurance get a hold of this information? These are all things I think we really need to grapple with seriously. And we need to try to figure out what people are comfortable discussing with us. So in the meantime, I also think we need to think about what are we going to screen for? Are we going to ask people about how they're functioning now? Because remember, a lot of people have been through a lot of things and they're resilient. They've got their church or they've got their community, they've got what they do, they've got a great family, whatever, and they're doing okay. They may not need us to medicalize everything that they're going through. Or we may talk to them and they may say, I am really struggling with anxiety, or I'm dealing with a lot of depression, or I know that a lot of my eating is about stress. In which case I may want to say, okay, who can I refer you to, right? So I may want to screen them for current functioning, okay? So that's where I think, again, these are just sort of random questions. I'm working on a paper right now on should we be screening for adverse childhood events in every single thing? And these are just some questions on my mind. So this is sort of like a, what was I going to say? This is like my diary. But these are some of the things that I think we have to grapple with on a larger scale before we start asking about trauma on a really big scale. But I also think this idea of screening for current functioning, depression, anxiety, coping, and then referring people, that may be a really good approach, okay? Because often our behavioral health systems are already pretty stretched also. So we don't want to be referring people that don't need referrals either, that may be doing okay. We also might want to screen for triggers in the healthcare environment. So if you are a medical provider, instead of asking what have you been through, you may say, are there any aspects of care that are difficult for you? So I actually have a colleague at the Society for Behavioral Medicine, and she's developed a healthcare triggers screening questionnaire where she asks patients, is it difficult for you if there's a procedure where the exam room needs to be dimly lit, or whether you need to be told to hold still. And people could just sort of check off, yes or no, this is a trigger for me. And then the clinician can actually discuss with them, okay, what can we do? Now that said, I actually think that our final frontier on this issue is really advocacy. So sometimes I have a slide. I don't think I put it in this deck, but my dad used to tell a story when I was growing up about how it was actually a poem, and it was supposed to be a funny poem, but it was basically about this town. It was a beautiful town where they had a hill, like a big hill, and it overlooked this valley below. It was a very scenic overlook. And people would go up there, they'd sit on the bench. The problem is a lot of people kept falling down the mountain into the valley below when they were looking at this beautiful view. So the townspeople split up and they formed a committee. And they decided, what are they going to do about all the people falling down the cliff? And half of them said, well, we need to put a fence around the cliff. I mean, it's beautiful, but we got to put a fence around it. And half of them said, no, we need a full-time ambulance in the valley. Okay, so the longer I've been doing trauma, you know, those of us in healthcare are really the ambulance in the valley, right? We're dealing with people after it all falls apart, and then we're trying to help you. But I also think we really need to focus on building some of those, you know, the protections so people don't fall down in the first place. And I really think, and David Finkelhor is a guy that's been doing child abuse research for decades. And I had the pleasure of actually just having a phone conversation with him. And so I want to credit him really for some of these ideas. And he said, you know, I don't think change on some of this stuff is going to happen just in our offices. I think change is going to happen in public policy. Things like a living wage, affordable child care, reduction in food insecurity, homelessness, you know, help for homelessness, gun control, working to reduce discrimination, sexism, so that people aren't at risk for violence and trauma. That's some of the ways that we can intervene on this. And I think that that's really, you know, part of what has to be part of this discussion as well. So at this point, I'm going to pause and kind of open it up to you guys for your thoughts.
Hi, my name is Tara Dabney, and I work for the Institute for Nonviolence Chicago. And we're currently partnering with Loyola and Rush and some other places to think through a trauma recovery center. Are you familiar with those models, and what are your thoughts on them, if you are?
So are you saying, like, sort of, is it for people who have already, is it for adults? Is it for children?
It's kind of a one-stop shop. It'll be community-based, but it will have hospital clinicians as well. So it's, if you've been sexually assaulted, if you've experienced domestic violence, our community experiences a lot of gun violence. So we're looking to have a community-based place where individuals can get the support they need after being exposed to trauma.
Yeah, I mean, I think that's a great idea. I also think that I think, and I don't know specifically about the center, I think the important thing too is to really build coalitions with communities and find out what's happening already in your community, because often I'm really struck with people who've been through a lot of things may already be using different supports in their community. And so sometimes I worry, quite honestly, that we are medicalizing trauma in a way that, you know, we shouldn't be, where we're saying, okay, well, these things happen to you, and now you need to come to us and we'll make it all better, and you need to see a social worker. Maybe you do, but maybe you don't. Maybe you can go and there's some community agency or some community support or your family or whatever. So I think it's important, not saying that they're not doing that, but I think they need to think about that.
That's the point of these centers, is to bring those people to one location, so sorry, I guess my question doesn't really make sense, but it's to bring people who are treating, we're community-based organizations who are working with folks in the community as kind of a one-stop shop, right? So people don't have to go to a hospital because they're not going, right? Or they don't have to feel crazy by seeing a clinician, but we can use words that are making it less medicalized, and people are able to get the care at a community-based location.
Right, or to just even know what's out there, you know, what services are there, or what community agencies are there. Like even in our our medical school on the west side of our campus at UIC, you know, our students don't want to come to something called a stress center because they're not supposed to be stressed. So we call it a resilience center, a wellness center, right? Yeah.
Hi, Val Talley, I'm the Chief of Maywood Police. I have one comment and two quick questions. The comment is excellent presentation. Can you push it out so that Loyola can get it to the people signed up? And then the question is, I didn't see a lot of information about the young people that are impacted by the traumas. I know that our community has an initiative where we're trying to push forward a program called Handle with Care so that we can align ourselves with school districts and young people so that anybody that's involved with trauma issues, you know, they can be looked at differently. So I wanted to know what you found in terms of young people. The second question is, as you're crafting your book, are you looking at the masculine male modeling and how that resiliency will impact that?
Ooh, that's an interesting second question. Wait, you're gonna have to remind me of that one. So in terms of the first question, yeah, I mean, I think you're absolutely right that the earlier you intervene in that sort of stuff, and part of it is I knew I was time crunched today, like, I can talk about this stuff all day. I have talked about this stuff all day, and we can expand a lot of this stuff about how the earlier we can intervene with people, the better off it is. Sometimes I will give medical students, I've actually had medical students ask me the question of, if you've gone through a lot of trauma, if you live in a violent community, don't you just get used to it? I've actually, not today, nobody asked me that today. But I think that that's something out there, right? Of like, why do we need to intervene early? Like, don't you just get used to it? Or you become resilient. I hate it when people throw around the word resilience when it doesn't really mean resilience, right? I think that there's a lot of education we need to do that we don't, you know, the fancy medical term is habituation, that our cells don't just get used to this. Kind of like if you were hitting my hand, at some point I'd just ignore it. I'd be like, all right, you're not going to stop, and I have to keep talking through this presentation. Right? But that's not the way trauma works. And so intervening with our youth is extremely important because there's so much data on the cycle of violence and how, for example, I think I cut it out of just time, but for example, boys who grow up in environments where they're witnessing interpersonal violence between their parents or their caregivers are more likely to be in those situations as they grow up. So the sooner we can intervene on any kind of, you know, things going on, the more important it is. Absolutely, absolutely. So I think that is where we need to focus our attention. Really interesting point. Your second point was about the masculinity and resilience. So tell me more about what you're thinking.
Men are trained and groomed in a model of being masculine. Cry and fall, hurt yourself, you know, and so when you expose yourself to trauma, police officers as an example, everything that we go to is bad. You know, how do you address that? They're just now saying officers have PTSD, right, which were reflective in our military.
Right, and you know what's interesting is in that kind of messy slide, and one of the things I had highlighted is the word emotional tolerance. And I think we have this idea that emotional tolerance just means, oh, I can take it, I can take it, I can take it. But it's actually almost like an emotional IQ. And part of it is learning to express, like I said, and I think you're absolutely right. There's probably a gender aspect that should be explored and thought about much, much more about how maybe we allow women to do that in our culture much more, and we don't, and even culturally, it's cross-culturally, it differs as well about how much we say we want to talk about things, or we need to let some of this out and talk about it and discuss it. So I think it's an important point. Oh.
Yes, to preface my question, I'm a case manager, special education teacher here in this community. Early in your slideshow, you made the connection between special education students and experiencing trauma. Now, to enter special education, you are screened for behaviors and cognitive functioning. Are you aware of any work trying to find the causation? Are students more likely to enter special education after experiencing trauma? or special education students more likely to experience trauma because of whatever had them enter special education to begin with?
Whew, that is a really good question. Again, I don't think offhand I don't think the literature has an answer to that question. I think that it's sort of a chicken or the egg, although when we look at the epidemiological studies on trauma, child abuse is much more likely with younger kids and kids who have developmental delays as well. So I think that probably those kids are vulnerable to abuse. And then once abuse happens, then of course there's cognitive delays. But I also think it probably works both ways. I do think that this is where the researcher part of me and not the clinician part of me thinks we need a lot more sort of longitudinal studies of like following people over time and sort of what helps kids, what's a risk factor, what's a protective factor. I think that's something that really needs to be explored more. So it's a good question.
Good afternoon, morning. I don't know what time it is anymore.
We've lost track.
Thank you for your wonderful presentation. I'm with the Illinois Public Health Institute, and we are looking at creating a racial equity cohort, a learning collaborative among our hospital partners. And as I was listening to your presentation this morning and your slides, particularly on policy changes, I started thinking about our purpose with little policy. What are your thoughts about healthcare institutions specifically addressing institutional and structural racism and its trauma impact on individuals as a way to be more trauma-informed care?
Yeah, I mean, I think that that's a huge issue that needs to be addressed, and I probably should add that to this slide, right? Or I don't know. Did I have something about that? I'm not sure. Yeah, I mean, again, discrimination, sexism, bias, racial equity should be in there. You're right, because that is one of the things that stops people from engaging in the care that they need, is if they feel like that institution as a whole doesn't understand them, doesn't understand their needs, they're not going to come and get help. So I think that that is a very important part of trauma-informed care. Oh, yes.
You mentioned very briefly the impact of documenting the conversations surrounding trauma in medical records. I'm a graduate student in law school, and I'm currently researching restrictions on things to firearm violence.
Yeah. First of all, thank you for doing that kind of research. It's really important. I don't know if you guys heard, did you hear what she said? She said she can we?
I'm writing my thesis on the impact of restricted police speech as it relates to firearm violence in our community, and also the complete inefficiency of federal veteran suicide prevention policy.
Mm-hmm.
So we don't have time for all that, but it's a really
unless you want to be here for like all week.
Right.
No, I think that's a really important issue. I mean, I think that part of what's nice for me to be in front of an audience that is not purely, healthcare providers or healthcare providers in training is the fact that some of you can go out and shape policy and can shape legal things. And I think that our healthcare system as a whole is sort of at this weird crossroads where we want people to talk about stuff and disclose things, and then we want to put that in the record, but then where are we as a healthcare? I don't know the answer to that. Where are we in terms of, can I discriminate against you for having a pre-existing condition? Well, now I think, according to you would know better than me, I think the ACA says you can't deny the insurance, but you could probably charge me a lot more for it. Is that right?
Context is everything.
Right? Again, it's hard to figure out. So, I mean, part of it is we're asking people to talk about things, but then what is to stop somebody that, is reviewing the chart and knows that, for example, interpersonal violence is related to a person's health later on. And they say, look, this is a survivor of domestic violence, so we should charge her more money for her premium. This is where we have to be careful, and we really have to figure out policy interventions that actually don't re-traumatize people. And that's kind of one of the papers that we're writing, is that I think we have to really think it through. And I think we really, as we are in this national conversation right now about healthcare reform, that has to be part of it, is like, you know, what kinds of things can you discuss that is completely confidential and cannot be used in decisions about how much to charge that person or to deny them insurance? Yeah.
Thank you.
Oh.
It's a community-driven coalition, and I would like to know how, or what would be your opinion on how community residents would work with institutions toward educating and giving them the tools to deal with residents on a regular basis.
Okay, so you're saying, like, how do you forge some of those partnerships? Yeah, I mean, I'm usually working on the other side of it, right? Where I'm telling clinicians, get out there and figure out what's happening in your community. But, you know, I do think that until we have larger, like you were talking about, the whole idea of getting community clinics that are you know, well informed on these issues and interdisciplinary, I think in the meantime, finding champions around this issue. So if your community stakeholders have certain providers that you feel like really get this issue and really care, to educate them about the services, because sometimes it's really, when you're working with different healthcare settings, it's because someone there has really kind of championed the issue and decided that it's important. So in the meantime, I mean, I still think we need to get towards more patient-centered medical homes, you know, where we have a nice cross-collaboration on services and community organizations. But until then, I think that that's part of it, is us finding champions.
And we'll take one final question.
Okay.
Oh, I'm with Ready Chicago Inglewood Outreach, and this is certainly not a critique, but more of a comment that we've tried to be more intentional about our language.
Yes.
And I learned recently from a staff person who said, maybe we shouldn't use the word triggered anymore, because we deal with gun violence, and sometimes people are activated in terms of their trauma and what happens to them. So we've been more, again, cognizant of not using the word trigger.
What do they suggest?
He said activates, like activators or something that generates that. So we stay away from that. And it's certainly not a critique.
No. I mean, that is really interesting. I once was giving a webinar and somebody gave the feedback of, don't use the survivor's story, because you're saying it's made up. So, you know, yeah, no, that is, so it's so interesting, right? We all get into our disciplines and PTSD, we use the word, yeah, interesting. Thank you for that. Oh, you have someone that really has their hand up.
So sorry to take a little bit of your time. I actually had, you know, an incident of a young lady that was really traumatized by an unwanted pregnancy and also rejection. And it actually took spirituality to really, really help this young lady, because at a point she wanted to take some overdose, you know, of medication just to commit suicide, and it took spirituality to actually help her. I was wondering, in your strategies to combat, you know, trauma, have you also looked into spirituality?
Absolutely. Like the literature, the data on, you know, what makes people resilient, when they say altruism and moral purpose, often that falls into that. That could mean many, many things for many people. And for some people, that means a traditional religious spiritual path. For some people, it means something alternative. For some people, it means community involvement. For some people, it means activism. But absolutely, yes, I think that could be a huge part of healing for people. Yeah.
Thank you, Dr. Raja.
Okay,
I know we could talk for days.